the tracking of what trauma is in the nervous system and how that dysregulates it is really, really critical to how you assess somebody, how you evaluate it, and how you see what's going on. And I think rather than the label at the top of going, well, I've got fibromyalgia and I've got EDS, and I go, you've probably got POTS as well. Yes, I have. How did you know? Because they always do, right? And you go, well, you're either really unlucky, or what if we could unpack the freeze and find out what was the original overwhelm that caused the dysregulation? And it's like there is a coping strategy that every time that person comes up against an emotional expression or a trigger or anything like that, there's a fork in the road that their system has learned to adapt with.
A lot of people with fibromyalgia may have come across the term of somatic experiencing, and even a lot of doctors, but a lot of doctors, and people don't actually know what is involved in it. Kind of, actually, if someone goes through a somatic experiencing session, what actually is it and how can it work?
This expression of trauma's not what happened to you, it's what happened inside your body in response to what happened to you. And it's added in the absence of a benevolent other. And that's really important. When we're alone, often, then there's the research is also that when we're alone, people tend to experience more trauma and overwhelm than when they are with somebody at that time.
Hi, Rodger. Thank you so much for coming on. I'll keep this brief because the reason I wanted to get you on was because your treatment for, in particular, chronic pain conditions, whether it's fibromyalgia, POT to some extent, is what interested me towards you. So just a brief intro on what you do and why you're a bit different to, the...
Right. So my background originally 34, 35 years ago was as a child physiotherapist. I'm kind of really... I'm proud of that background. Our roots I'm fine with. But I've studied lots of other things along the way, and maybe we'll chat about those. But I'm proud of it, and I really appreciate it because of the solid sort of pharmacological, physiological, anatomical background that it gave me. And also, I am very aware, there's no disrespect to amazing young physios coming up, but, I mentor some within my own practice that they're not training people in the same way. They're not trained with manual therapy in the same way. We seem to have gone into very much an exercise paradigm at the moment. And there can be all sorts of reasons as to why that's happened potentially. But certainly the depth and the detail of the anatomy, the neuroanatomy, et cetera, isn't the same. It just isn't. Now, whether they just felt that was like unnecessary level of information, but, I was thinking about this today when thinking about coming on here, that has allowed me to think more laterally when it comes to treating chronic complex health problems. If all I got was this sort of narrow field of muscles, bones, joints, ligaments, nerves to a certain extent, I'd be really stuck because I wouldn't have the understanding of the organ structures and the interrelationship between things. Mm. I'm not saying I wasn't taught about this because none of us were, and we're only just sort of figuring it out, really. But I've always had a curiosity for those patients in a way that don't get better. We pat ourselves on the back. The ones we help, that's like, hey, great, oh no, wonderful. But what about the ones we don't help? And then they're the really challenging ones because that's, I think, where we have to think. Also noticing patterns a long time ago in patients where they would often have lower back problems with irritable bowel or some kind of, inflammatory bowel disorder or something. Lots of people who were having shoulder, neck problems with thyroid issues. And then when you dig into it, had lots and lots of issues with tonsillitis as a child, and you go, well, this is curious. And when you start seeing that pattern again and again and again, you go, there's something in this, but I don't get it. And so I've looked far and wide. I studied traditional Chinese acupuncture many years ago, over 30 years ago. I trained in craniosacral and craniosteopathic techniques. I've looked at energy medicine, different how different cultures deal with trauma societally. I've been a Zen student, martial artist for 20 years, and the list goes on. Certainly somatic experiencing, sensory-motor psychotherapy, and more latterly with the amazing Alien Pierre, a wonderful thing, neuroaffective touch. I had, as you might know, to work this stuff out myself because of my own healing journey, like for many others. So around about 20 years ago, I got very unwell with relapsing pericarditis. I had about 14 episodes in a year, and the pericardial effusion was around about 2.5 centimeters either side, so very large. Crushed the heart in the middle, ended up with cardiac tamponade.
Oh gosh.
Flatline. Wow. Fortunately, actually, when I flatlined, I was in coronary care at the time. And it took me, the steroids took the swelling down, but every time I came off them, it just kept coming back. And so I had to figure out, why is my body inflaming itself? And why was I still, is this an element of, is there chronic pain? And we'd had some echocardiograms that went, that's really interesting because all the swelling's gone, but you've still got pain. Right, interesting. So there was potentially some chronic inflammation, and there was also certainly some chronic pain in the absence of inflammation at times. And so that took me on a very long journey of physician heal thyself, figure it out, try and practice what you preach. Yeah, I suppose that's the background to me a little bit. Yeah.
Wow, okay. Amazing backstory and experience. It must have been, not many people have had a tamponade, flatline, come back, come up with treatment themselves and other people. So that in itself is an amazing backstory. But what's also very interesting is your kind of rounded experience in sort of the alternative space. So you mentioned, a lot of things there. So, acupuncture, Zen therapy, martial arts, even to an extent, somatic experiencing, and obviously your main kind of background, physiotherapy. And I can see the backstory as to why you kind of went through all of them. So today, is your practice kind of merge around all of those experiences, and if so, what is there one that's kind of better than the other, if that's the right way to say it, or is it kind of, because obviously doing the bulk time of physio wise, people, because when you say physiotherapists, people, they kind of assume, they're just going to tell me to do some stretches and go home, right? If you ask most people, what does a physio do? That's what they'd probably say, because of the experience with the NHS. But what you do is very different, and I'm guessing it's due all the experiences you've gone through. So say if a patient comes to you, let's just go straight with fibromyalgia, right? Because it's the most, in my opinion, one of the most troublesome, conditions out there. Where do you start with them, and what do you do to help them?
Okay. One of the things that I teach a lot to my physio team and to anyone that wants to listen really is, I think we can really make massive headway by getting rid of the label to start with. Look, labels are really useful. They're great communication. We go, well, we've got to communicate somehow from one, professional to another, from one person to another. And we got to go, well, what are we going to call this? And people kind of want a label. And we all know there can be some relief when a patient who's struggling with some incredible symptoms finally gets a diagnosis. And that's the way that we're all traditionally trained. We go down some sort of flow chart of, well, okay, you've got this and this and this and this and this, and therefore we'll call you this. Now, actually, if you look at fibromyalgia, chronic pain, chronic fatigue, ME, long COVID, even to an extent, you start seeing huge overlaps. Many of them suffer with pain. Many of them suffer with brain fog. Many of them suffer with, loss of movement and function, and so on, and fatigue, and so on. And so, where does one begin in the other end? And so, in a way, I don't go, right, well, I've got a fibro patient coming in. I've just got a person coming in, and I want to go, what? Tell me your story. Tell me what's going on. And very often I'll say, okay, and what else is going on? What symptoms are going on? I think very often, we'll try and put them into a box because, we've got that symptom, that's part of our diagnostic pathway. Okay, well, I've got this hypothesis. I think it might be this. Let me go and do some kind of ancillary tests, some bloods, an MR, or whatever it is, or I'll look at them physically and go, yeah, there's my physical exam. That's how we conclude the diagnosis. But, so often I'll get people and they'll say, well, I get pain in my jaw. Okay, TMJ problem. Right. Okay. And what else do you get? Where else do you get these symptoms? Oh, well, it's all over the place. Okay. And do you have any other health issues besides the pain around your body? Oh, yeah, but dreadful irritable bowel. Okay. Um, yeah. And when did you first begin? It's the greatest question. We also said, when did this start? I was in conversation with one of my colleagues today, and he was sort of sharing something, an experience from a patient, and I said, it really does change it when you ask this question. He said, yeah, it does. He said, what was going on in your life and in your world when these symptoms began? It's a different phraseology, but my goodness, it really creates, try it, with your own patients. It yields different results. What was going on in your world around about the time when you began? Because it opens the conversation up into the sort of relational life, external factors that were going on. So, I don't know whether I'm answering your question, well, I am, but perhaps not in the way that you thought I was going to answer.
It's very interesting because absolutely, because one of the key things with these chronic pain syndromes is normally, well, often there's lots of things in the patient's background from when they were a child maybe, but there tends to be a specific trigger surrounding events of whether it's a physical trauma like a car crash or excessive event where they were training for a marathon or mental trauma. So I think that's actually very important. I think something that especially doctors, especially GPs in 10 minutes, don't necessarily, well, even if they do ask, it's very hard to go into detail or in depth to the point to which you need to help the person.
Yeah, and I think it's one of those things that you go, well, if they told me that, what would I know what the heck to do with it? I mean, that's the other thing, do we know what to do with it when we get the information? So, what I've also, if I've got somebody coming in and it looks quite straightforward, most of my work is most of my colleagues will see something if it's a fairly straightforward, I don't tend to treat sort of knee injuries, back injuries, et cetera, et cetera. Most of my work is, well, almost all of my work is in the chronic complex field. So I pretty much know that when someone's coming in, I'm not going to get a normal, well, I was skiing last week and I twisted my knee. I'm not doing that work anymore. But the questioning, and also, and you said, well, is there a particular technique that I use most? Somatic experiencing and other things around that. So I had to kind of figure things out kind of the hard way, really. Really, 20 years ago, I mean, Peter Levine, the founder of Somatic Experiencing, was doing this work, but not really teaching it much in the UK. And it wasn't known about, and I certainly didn't know about it. And so I then training in Somatic Experiencing, I kind of went, yeah, of course, it was great work, but there was a lot in there that I'd already kind of figured out and picked out from other systems of thinking and my own work. Watching people's physiology, what you get really good at is really noticing unconscious body language, noticing their physiology, noticing kind of almost when we talk about being in resonance. It sounds a bit weird, but in sort of Gestalt psychotherapy, they'll talk about the field. And you can literally feel, and perhaps you've experienced this as a doctor, you sometimes there and you just go, if I'm really in tune with myself, whoa, I could feel like something's going on. Are they going to cry any moment now? You can sort of feel it before it happens, right? The more attuned you become to noticing that, or even going, I'm just noticed my own chest gone tight. That's interesting. Or you want to catch the dysregulation in the system. You're watching for what's going on in their physiology the whole time. And I mean, well, we can go into it if you want to, but perhaps beyond not the emphasis of the chat today, really, but the tracking of what trauma is in the nervous system and how that dysregulates it is really, really critical to how you assess somebody, how you evaluate it, and how you see what's going on. And I think rather than the label at the top of going, well, I've got fibromyalgia and I've got EDS, and I go, you've probably got POTS as well. Yes, I have. How did you know? Because they always do, right? And you go, well, you're either really unlucky or there's something going on underneath it. And what if I could tell you that I think I might understand what's going on underneath that causes all of them, all of those presentations? And they go, wow. And usually there's some form of dysautonomia in there. Now, why the system has been altered, why there has been a shift in the way that the nervous system, but other systems work, that's effectively what the traumatic event was. So, if we think about sympathetic nervous system, the autonomic nervous system, sympathetic, parasympathetic, yes, we can have normal fight, flight, but a lot of freeze if people become overwhelmed. And to your earlier question about fibromyalgia and chronic pain, if we look at freeze, then what does freeze, how would it look? Well, it's high muscle tone. Yeah, it's a rigidity. And it's an inability or a thwarted motor response. There's a wonderful video you might have seen of a polar bear on YouTube that's been traumatized by it's been pursued by a helicopter and it's been the fight-flight response has been arrested. You know the one I mean. And then he goes into a neurogenic tremors. Okay. Which look like they're random neurogenic tremors, but when you watch the slowed down version, it's a completion of the motor response of getting away. And sometimes we will see as we work with people that come out of freeze that they will begin to tremor. Now, this is not the only part, but a big part of so-called fibromyalgia, because we all know there's no fibrotic tissue really going on, and if it is, it's just simply because the myofibrils haven't been gliding against one another for a period of time because they've been locked up in freeze. What if that freeze response is an overwhelm of their nervous system in response to emotional stimuli? Yeah. And we get these patients, don't we, with IBS and depression and chronic back pain all the time. And they're not three separate things in my mind, or most of the time they're not. So what if we could unpack the freeze and find out what was the original overwhelm that caused the dysregulation? And it's like there is a coping strategy that every time that person comes up against an emotional expression or a trigger or anything like that, there's a fork in the road that their system has learned to adapt with. And your job as a clinician is to catch that and then go, I can see where the unhealthy pattern is beginning and the dysregulation is beginning to happen. And then you catch it and then go, what if we can support the system, maybe bring in some, vagal tone or something or other, where Porges' work comes in. We can then start to regulate the system, slow it down so that actually they don't go into the old pattern of overwhelm and freeze. And you start to retrain the system. So I think fibromyalgia is very often a lot of rigidity associated with freeze.
It's interesting because I think some of the theories are not with everyone, but there is some good evidence out there. So, in the first kind of 18 years of life when you're still kind of almost pruning your nerve system, if something happens in those first 18 years, like I mentioned, it could be like, whether it's an abuse, neglect, even in some cases, excessive sport, that kind of, it may not necessarily cause anything there, but it kind of, those circuits are remembered. So therefore, in your 20s, 30s, 40s, 50s, when you do have a traumatic event, your nervous system is kind of, primed to act on that, I guess, sensitized, which is where that event is so important. And it's interesting because a lot of people, a lot of people with fibromyalgia may have come across the term of somatic experiencing, and even a lot of doctors, but a lot of doctors, and people don't actually know what is involved in it. Kind of, actually, if someone goes through a somatic experiencing session, what actually is it and how can it work? Because a lot of people think, when you first explain to them, they think, oh, this is a load of nonsense, how is movement going to work?
Yeah, and actually, sometimes it's not movement, we talk about somatic experiencing here, but I think, there are a lot of similarities as to, I'm speaking this year at, I've been invited to speak at an EMDR and chronic pain conference in York in June. And, one of the things that I'll probably be putting into that is, obviously, I'm an EMDR practitioner. That's another one of the things I've done along the way as well. The more you look at the different systems of medicine, one of my whole kind of philosophy around a lot of things is the more you look at different systems of medicine, the more that you realize there are massive similarities. And if we do it the same way as I look at the kind of health conditions, if we look at approaches to medicine, instead of just our ego getting in the way of going, well, that's nonsense and blah, 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 and this is better than the other, if we have a lot of humility and kind of go, well, what if we could overlap them and go, well, what similarities exist? And certainly whether it be EMDR, sensory-motor psychotherapy, somatic movement therapy, or somatic experiencing, or anything that is in this sort of restoration of trauma realm, working with PTSD, working with ACE scores, which perhaps we'll come back to, which is kind of what you were referring to, I think, really, this early years influence. The watchword is slow it down. You're trying to slow things down, and you're trying to create sort of corrective experiences within the system. So I like analogies and images, and if you try it's like dominoes toppling. And I don't know, let's make a scenario up. Okay, an archetype of something that might be called overcoupling within somatic experiencing is a PTSD war soldier. So if he hears the sound of a car backfire, he might be in sunny Wokingham here, but within about 100 milliseconds, because that's how fast his autonomic nervous system will happen. It's as fast as a pupil changing. It's a very fast response, certainly for a sympathetic activation anyway. Within about 100 milliseconds, he's going to have potentially physiological responses. His heart rate's going to go up, potentially. He's going to probably physically hit the deck. He may be having flashbacks of time in Afghanistan, Iraq, or wherever he's seen service. He may have immense emotional elements like intense fear. And there will be the brain will be having thoughts of and making meaning out of that of I'm going to die. So there's an acronym used within sensory motor psychotherapy and also within somatic experiencing of SIBAM. Sensation, image, but all that image can also be in any senses, so taste, sounds, etc., etc. B is for behavior or physiology. A is affect, emotion, and meaning. And I won't go into it now, you can undercouple, overcouple, get distortions in that. So for every experience we have can be made up of those elements. And I've kind of tested this, and I think it works. If we're going to process something and it's going to be within our ability for our body to process that, it needs to be able to sort of have all of those pieces of the jigsaw, and they need to be manageable, and they need to be together, and for the body to be able to cope with them. As people like Gabor Mate have really brought to our attention, trauma's not what happened to us, it's what happens inside our body in response to what happened to us. I can't unbomb blast a war soldier. So how do I help him? And talking about it won't make any difference. I'm not knocking talking therapy. I've had 9 years of good psychotherapeutic work in my own journey. It's very important. But for trauma, we know that it can sometimes make it worse. Why? Because if you're not catching the physiology and you're just talking about it, and you're not catching it, you're re-traumatizing them. And so you need to slow it down like these dominoes. And if you catch it and you go, right, as we talk about that, can we pause there? Then if we slow it down, we've got a chance of stop hitting the next domino, and off we go. And it's too fast. EMDR, somatic experiencing, sensory motor psychotherapy, all sorts of different approaches to treating trauma, all have the interruption and the slowing down. That's a common theme.
So, put that into a bit of an example. Say if you're seeing somebody, and you mentioned a lot about observing their physiological response. So say if you're having a conversation with them, and let's use a patient who's got fatigue, chronic pain everywhere, fibromyalgia, but not putting label on it, right? But that's their symptoms. And they're saying, it all started with a massive divorce, quite a common trigger 5 or so years ago. And you notice as they say that, you could just tell, their pupils might, constrict, or they might start, the expression might change. They might go into the freeze mode, right? Which you can pick up on. If you catch that then, and you see that in their response, what can you do? Yeah.
Again, the thing is, there isn't a recipe book. There are many things that we can do with it. There are many ways that I might tackle it, and this is sort of the art of what we do, as much as the script is to do this. It's more complex than that, but certainly, if someone was saying something, very often what you find is that people won't notice it. And one of the things that people will do is they will very often get good at finding ways to cope. because they had to. And so one of the things they might do is what I call skimming stones. So they might speed up in their speech, and they'll begin if you go fast, and you skim a stone across the top of the water, it never sinks into the lake, which is where the deep, dark monsters lie. So that's why you'll get those patients who speed up, talk fast, and actually they'll really feel uncomfortable often if you invite them to pause, because then that brings about, oh, there's a rise. Okay, is it all right? And then they'll be like, what's going on here? And then depending on what it is, if it's a divorce, that might be, okay, can we pause there? Because this sounds really big. Of course, there's a relational piece here, that, and it could be that you make contact with them and you say, wow, or can we slow that down? Our presence, there's some stuff here around, that the presence of another regulated nervous system. There's some science around this. If this is co-regulation, as it's called in sort of the vagal world, that if our nervous system is more regulated, so this is where the work of being a therapist is to do the work on yourself, a lot of it. Because if you can notice that and you can hold the space, if you will, and you hold your own nervous system, because there's a regulation between two human beings, that's going to actually influence your nervous system because you're sitting in my proximity. Now, that sounds a little bit woo, but there's good science for that. Yeah, if I slow my heart rate, yours will slow. And if we even get to this is where we start looking at, how indigenous cultures deal with it. They would never, ever leave someone to deal with trauma on their own. All trauma in indigenous cultures is dealt with in groups. So, Peter Levine, I had the pleasure of being in a master class with him a couple of years ago, and you had the expression of trauma is not what happened to you, it's what happened inside your body in response to what happened to you. And he's added, in the absence of a benevolent other. And that's really important. When we're alone, often, then there's the research is also that when we're alone, people tend to experience more trauma and overwhelm than when they are with somebody at that time, even in the realm of sort of people paramedics with them, etc., etc. How that's handled makes a big influence on how their system copes or doesn't.
Absolutely, yeah.
And so we might be that we actually just make contact with them, or we put a hand on the back, or we just go, right, what do you notice there? And we get them to notice the pattern when hopefully it's still within their window of tolerance. Still, it's not gone, I've lost it, and gone into what we call the trauma vortex. If they are in capacity, that's a sort of like there's a river, and trauma is too much, too fast, too soon. Or in the case of neglect, not enough. If there's too much rain, too fast, or too long, then what happens is it breaches the riverbank. And so, but then it's not within the capacity of the river to process it, and it can't move on, and it floods. Now, if you imagine that, you ever took your kids or whatever to the swimming pool, and they have these kind of the rapids, they call them, and you can sort of feel it pulling you off again. You think, oh, no, I want to go off and go to the pirate ship. No, we're in again. We just got to go around, right? If you were going down the river, you would feel the turbulence and you would feel the pull, right? If you were in a canoe. Well, that's how it is. What you're working is to feel that and help people to try to come to feel the felt sense and the experience of going, oh, this is familiar. And really, this is what people talk about when that kind of slightly allergic reaction to the term trigger, because it's very overused right now. But an activation of the system, a trigger, is something where you go, that's familiar, and it's the same big early sensations and experiences that happened back then when the trauma originally happened. And so the body then goes, we're there again, and we know how to deal with that. And what we did with it last time, there's the fork in the road, and that's what we do. And our job as therapists is to be able to notice that, clock that, and help people to slow it down, catch it, interrupt that, and go, whoa, okay, can we be with that now? Okay, what is there an emotion with that? Can you be with that? No, it's too much. And then we might offer strategies to help them to go, right, okay, let's try this, that, the other, to help them to regulate that or to process that differently. I mean, it's still a very kind of surface level kind of how to describe how that might work from a somatic experiencing. Or you might use EMDR. This is where you might go, if we could go to a timeline, slow it down, right? Sometimes called T0s over here, and you at that point here. Slow it down. Can we use the EMDR to interrupt the process in some way to allow reprocessing?
But Roger, what kind of dictates? I know it's hard to say, and it is very obviously you need to, you're very individualized. But what kind of, when do you decide, or how do you decide what may work best? Because you mentioned EMDR, you mentioned somatic experiencing. There might be some actual physical manipulation, right? You can do, like. Yeah, so I don't know if they blend very close together, right? Someone might EMDR and somatic experiencing and physical manipulation, right? All these things. But how do you decide where to go first as where you can get the best bang for your buck kind of thing?
That's a great one. This is, I suppose, is the skill of years of doing it. And it's a great question. And you go, well, why did you choose to do that? And sometimes you go, I'm not entirely sure, because you've just done it for decades. Look, I think somatic experiencing is a good place to start. There's a really nice framework for that. But I think it's a wonderful term actually, because it is about an experience. It's not just, there's a lot of stuff in the nervous system right now, but there's more to it than this. There is fluid dynamics, and Amy Lapierre, who she's editor-in-chief of the Body Psychotherapy Journal. I've had the pleasure of training with her, and in fact, I'm assisting in teaching with her in a couple of weeks' time in London. And her work is wonderful. So there's a lot of touch in that. Now, that's was very geared towards early developmental trauma. And so sometimes the nature of what it is, if someone comes in, so I'm trying to answer your question succinctly, and I'm not good with succinct.
It's a hard question to answer, so I appreciate you trying.
But, so shock trauma, my experience is, speaking at the EMDR conference, and people often say, well, should we try EMDR? And I said, well, look, we could. My experience of working with them is I think EMDR works quite well with single event shock trauma. So if you've got somebody who's been in a road traffic accident or something like that, it can work really, really well. But if you've got somebody who's got more complex trauma, where there's maybe developmental elements to that, or it might be, I don't actually think, think of your example of, a gentleman gone through divorce and then his symptoms beginning at that. I probably wouldn't choose EMDR if I'm honest. Now, I can probably be EMDR therapists or practitioners listening to that say, well, no, yes, I work with that. You know what? Yeah, you probably could, and I could apply the principles of it and get some results. I just find that I think that other somatic tools are richer. If you get a sense, there are certain things where, this is where we get into things like attachment theory and attachment trauma. If you're getting a sense that there's some attachment trauma that may be earlier, and you probably won't pick that up on session one, you probably won't. But certainly not if you've got somebody who's coming in with divorce, then you're going, okay, well, there's a grief element around that. But we're going, well, how was that? I mean, how did it happen? Did you know it was coming? Did you sense it? Was it she just packed up, you turned up home from work one day and she just had gone and she'd taken the kids. I mean, the nature of that is a very more sudden shock event. Was there anything else around that? And if there's a shock, it's like, as they're telling it, you're probably checking and you're going, what do they look like? And if they're they look like they're sort of zoning out slightly and dissociating slightly, then I'm going, okay, as they're telling that narrative, their system is starting to get overwhelmed and they're going into the pattern that they used to cope with it. So let's interrupt that pattern and let's see what we can do.
I see. Now I'm going to push you on this because say people listening, like we know, okay, so we've got to the point where, okay, we found a fork in the road. We found, where we need to take action. So you've thought, okay, I want to try some kind of somatic experiencing.
Yeah.
What does that look like? So what is it? Okay. Is it words? Is it like, because we know what's somatic,
got it.
Right? But like, are you saying words to the person? Are you intending to imagine a certain situation they're in? Or are you telling them to move certain ways?
Okay. Right. Yeah. So with somatic experiencing, actually there's far less words and you can have immense silence. So what you'll be doing is you might then say, okay, all right, what do you notice? If we pause you right now, what do you notice? And they might go to their thoughts and they might say, oh, well, da, 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 because often we'll go to the thought and we'll go, okay, so that's the mind saying that. So as you have that thought, I've just paused you there because, what's going on for you? Any kind of emotions there? Any kind of sensations in the body? What do you feel? And they might not notice anything, or you might go, you know what? I just kind of noticed that your neck looked like it just went quite rigid, or your shoulder pulled forwards here. I just wonder, what do you notice? Because you slowed it down. Oh yeah, I can really. Oh yeah, I can feel that tension in my neck. Yeah, right. Okay. And then it might be that we'll go, in the medical world, we would understand titration from a sort of pharmacological point of view. And I use this analogy of, if you take the lid off a shaken up Coke bottle all at once, you just make a mess everywhere. So you do the same thing with this. If you try to release the trauma from the body too fast, it won't work, and it will just overwhelm it and shut it back down again. So you have to titrate it. You just go, ooh, what is that? So I wonder if we can, that movement that wants to move there, could we slow that movement down? Can you if it could just move 2-3% of that? Right. Then you start to break the freeze pattern. Maybe. Right. So it might be a movement, or it might be, okay, as we're at the, what do you notice? Oh, I'm just seeing the look on my kid's face. Okay. Right. Okay. And as you do that, is there any emotion there right now? No. Wow. I mean, where's it gone? So that's an undercoupling element. Where is that? Because that sounds a lot. So where is that? Yeah. Okay. I feel a bit. Or they might go, I feel a bit something here. What's it feel like? It feels a bit tight. Feels a bit wobbly. Can we just be with that? But there's no emotion. All right. Okay. So it's coped with it by going disconnect from the emotion. You can't process it because it's not there. So that's an undercouple, not an overcouple. And so that you work with these coupling dynamics. We might use movement. We might say, okay, suddenly if we're thinking, oh, well, there's some developmental things here. We might say, actually, there's an attachment rupture here. Or they're saying, look, this began when my mother died when I was 10. Suddenly, okay, right. Or even very young. Or actually you find out in the history that you go, look, my mother had borderline personality disorder or something or other, and you go, right, okay, how was that? Well, it was like, I never knew what was coming. It was inconsistency. Okay, so is there some attachment stuff? So as they're dealing with this emotional challenge, I might go, would it be okay? How would it be if I just put my foot next to your foot? How would it be if I came put my hand on your? And then sometimes you'll get this thing where somebody will just say, I had somebody recently, and they just went, all right, is that settling? Yeah, right. That's settling the system. Great. Wow. And then they might say, I don't think anybody's ever had my back before. Oof, wow. And then you're into the sort of the psychotherapeutic elements of that. What is it if we use neuroaffective touch and say, okay, that might make me think, right, well, what if I actually apply some support, put them on the bed, put my hands underneath around where the sympathetic ganglia are coming out from the spine that might support the bracing. We might use warm pillows down the front here to sort of say, well, let's send some signals down through the anterior surface to try and get some parasympathetic. All things in the nervous system in trauma are about safety, 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 safety. And how can we create bottom-up messages from the body to go, how do we settle the system? How do we engage parasympathetic? Maybe. This is where Stephen Porges' vagal brake comes in. But then, one of the other big pieces, and maybe I'll shut up and you can ask another question, but there's another big piece which I feel quite passionately about. In fact, we mentioned a mutual friend, Deepak Ravindran. I was having coffee with Deepak not long ago and was sharing something with him because he was talking about, should we look at vagal stimulation machines and stuff? I said, well, yeah, maybe. But you know what? There's organic ways of doing that. And I said, and the challenge for this is there's so much stuff in the somatic world right now that feels like it's all about vagus, 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 vagus. And I'm going, right, but you don't want to always settle it. Because if you just avoid it, you've got to fly the kite in the wind. So this trauma vortex that we've talked about, you actually have to go there carefully. in the end in order to be able to process it. So if all the time you're avoiding it, so certainly as people gain capacity, you might over a period of time build their capacity, and then we don't want to keep settling it. Once their system knows that they can lean in, pendulate in and out and in and out, and you've titrated some of the charge out, there's less ferocity to it, you can then lean further in, knowing that their system has learned how to find the vagal tone to hold the kite as you fly it in the wind, so to speak, if that makes sense.
Yeah, I mean, it does slot. I mean, so just to so a lot of people are asking me about these devices you can wear. There's various ones out there. They're essentially, what you're saying, they're very expensive kind of vagal stimulators, right? So there's what Neurosim, Parasim, essentially, and they're there for migraine, IBS. But essentially, you can stimulate the vagal nerve just by, simply by rubbing your crotchet, right? There's different ways you can do it, cheaper ways to do it as well. But which is essentially what you're doing. But just say that piece again. So what you're saying is if you calm, because the vagus nerve we know essentially calms the system down, right? So it will slow it down. You're saying if you calm it down too much before the person knows that they're leaning into their trauma, going to the depth of their trauma or getting to the trauma vortex, which is what you have to get into eventually. You're saying if you try and calm the system down too much before they get to there, you're saying they'll never get there. Is that what you're trying to say?
Kind of, yeah. So there's an expression, kind of, that which we resist persists. So so let's say, for example, every time you get into a conflict and you start to feel and experience, every time you just dissociate and you split away from that, that in a way a dissociation, there's nothing wrong with dissociation. We all do it, actually. We all sort of slightly zone out a little bit from time to time. But if we're using that a lot, then in a way that's a disconnect. And certainly if you want to try to get into changing the pattern of going back to the trauma, ultimately you do need to go back into not the narrative so much. I mean, that sometimes comes, but into where the body's dysregulation pattern happens. You've got to go there, or else it's not going to change. Because if you don't go into the sort of, you'll never get neuroplasticity. I mean, we would look at neuroplasticity of how that actually happens, and then that's not going to happen if you just keep avoiding it. So every time your body starts to go, oh, well, as I relive this story, all of a sudden, the patient's eyes are sort of rolling out and they're gone into some kind of dissociative seizure or something. Well, you can't just go into the dissociative seizure, but neither can you completely ignore it, because guess what? You're going nowhere. So the skill is being able to know how to go into this sort of trauma vortex in a way, delicately, without re-traumatizing the person, to be able to create neuroplasticity, change the processing habits of the body. That makes sense.
What's your thoughts on people? Because there's quite, I've seen recently a lot of people are asking, because so obviously doing one-to-one is probably the best way to do it, but because of cost reason or whatever it is, a lot of people are now, which is I think how it works are, people are doing it in kind of larger groups or like online groups or communities where it's almost done virtually. So, so you might have a person on a Zoom call doing it to, maybe 100 people or whatever. How can they work? Because I'm guessing because it sounds like we're listening to find almost like a specific trauma for the person. So, and some people do report really good results with it. It's better than not doing anything at all, right?
Sure.
So how would they work? Because, I'm guessing I give almost like generic kind of scenarios and telling the person almost to touch themselves, in certain situations where they feel like they would be there.
Online can work. I've seen it work, and I do that, but I only do it one-to-one. That's the way I choose to work. I never work with more than one person. I know, and I know of other forms of somatic practitioners around the globe who do that work. I'm not saying it's nonsense or wrong. I mean, they get results. But for me, just a core principle, I've never really liked groups, even back in my whole physio days in the NHS. I never liked trying to do knee classes or back classes, because it's not individual enough. And for me, I can tell you, the individuality and the nuances taking place between one person and the next are immense. And there's no recipe. This is why probably wanted a clearer description of how I work. And the reality is, I've given you one example. There could be 1,000 other examples because there isn't a recipe. You can't just go, okay, do this, wave your arms about, clap your hands 3 times, and it's all going to be fine. I wish it was that simple, but it isn't. So I don't know, is the honest answer, how on earth you have 50 people on a Zoom call and have effective somatic therapy. I don't know. I'm not sure I can answer that question, to be honest, because I don't do it because I have no idea how I would achieve it. I have no idea how. Now, maybe I've just avoided it and I need to speak to some people who do it.
It's interesting because a lot of people have.
I don't know how you do it.
Yeah, I mean, I know a few that are really big. So, I mean, a few online. I won't name them, but there's some are like really large and, have tens of thousands of people gone through the program. But obviously talking to you it might be the right question to ask you because obviously speaking to you already, you can tell the way you do it is almost impossible to do it to more than one person at a time.
I think so.
I'm guessing you're very busy, and I think, but why do you think the cases of all these chronic things have gone up massively? So recently, and in I know you've probably seen it, but especially
chronic illness or chronic pain. Well, all of it.
Yeah, but in particular, both actually. You can pick either or. They're both gone up. Chronic pain, chronic illness.
Yeah.
Why do you think that is? What are the kind of things you're seeing, and what's your kind of thesis on it all?
Right. So there is no doubt, and I'm certainly aware from my peers around the globe, that we have all seen big shifts since the pandemic. There's no doubt about that. And if we look at anxiety and stress, actually, if you look at quite a lot of health data in relation to wars and things like that, there are often spikes in health issues following wars. I think that there's an element of we're much more aware of the sort of the mental health side of things now than we were even 20 years ago, never mind at the beginning of my career. And, I've been quietly doing all sorts of different things for decades now. Was working with fascia a long time ago, 15, 20 years ago. Got ostracized for it because I dared to mention it to a spinal consultant who worked with me closely, and then just ostracized me and just referrals dried up overnight because I was talking about fascia, and he just said, well, what are you going to do with that? Swallow a large bolus of food. And it was like this was an inert structure that we all dissected and stuck in the bucket in the anatomy labs. And actually it's so rich, and there's photons of light passing through it, and there's communication taking place. The importance of the fascial system is immense. Now we're all seeing it, and so there's an acceptance of the mental health, I think, is now important. Now, if we look at, I think I think most people in the medical world that will say, look, often, very often, the vast majority, I would say, of conditions which present to healthcare practitioners are often got a very large stress element to them, the more we look at them. Yeah, okay, even epigenetics. I think, if we look at the impact of stress, and this is the piece that we haven't got into, and this is the piece that's, for example, somatic experiencing doesn't really get into, well, it does if you're at a sort of a higher, faculty level. And I think people have had conversations with faculty members there, and they say, yeah, we get it, but we just don't put it into the training because where do we end? We could go on forever and ever and ever. It's a big, 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 big subject. But the PNIE system, the psycho-neuro-immuno-endocrine relationship of systems or systems concept is important. And if we look at what is overwhelm? What is trauma? Well, it is something which is overwhelming. And for many people, for all of us, the pandemic created a lot of challenges. There was either loss of loved ones, there was fear over, crikey, when I went through it, I had to remortgage my own house to keep my practice alive. It was a 6-figure sum that it cost me. It was a huge, huge hit for people and wondering whether businesses were going to go under. This pressure of family dynamics with people being hemmed up in their house together. You mentioned the ACE score stuff, and we're going, well, look, if we look at the delayed reaction of that, And you go, well, what's happening with families? And the number of divorces went up post-pandemic. Yeah, and what's happening to kids where the pressure cooker in the home is, well, dad's going to lose his job and mum and dad are at each other. And, what kids are not actually connecting with each other because they can't, because they're not allowed to. There is no doubt that the challenge and the trauma to the system for many, many, many people for all sorts of reasons, whether it bereavement, loss, I can't go to somebody's. There was a lot for people's systems. And so if we are saying this, not just as a sort of psychological concept, but I think the really beauty is to sort of say, well, okay, well, I've got grief. Yeah, look, as I said to, maybe this will help, I don't know, because we really have this, you've got to bridge this gap between the mind and the body, what we think mind is. And it's years since I considered mind to be in the head, quite frankly. Mind is an entire body experience. That's just your brain in your head. That's it. And I said to a psychotherapist that I was treating a couple of years ago, and I said, well, look, when was the last time you felt an emotion in your brain? And she looked at me, and I kind of went, never. And she looked at me like, this guy's mad. I need to leave the room. What's he on about? And I said, no, I didn't say it wasn't processed somewhere in the brain, the amygdala, the hippocampus. I didn't say that. I said, when did you feel it there? And the answer is never. You can't. You could stick a pin in your brain and you'd feel nothing. Stop stuff working, but it wouldn't hurt because you can't. There's no nociceptors. It's not possible to feel pain in your brain. And yes, Lorimer Moseley, all these people, the pain in the brain, I get it. But the piece that we're missing is like, what about, how do you know where your nervous system is? How do you know when you're getting overwhelmed? How do you know that? Well, because you experience it. You feel heartache in your heart. You feel sick to your stomach. We feel collywobbles. We feel a shiver down our spine. We feel like someone's getting close to me, our proximity. Someone's in my space. We feel it. And this is why I think actually I get people criticizing me on YouTube. We're a physiotherapist. What the heck are you doing? And I'm going, well, listen, I've got a bit more than a physiotherapist these days. But this is where the body is so important. And a lot of my peers have been trained with, have been psychotherapists. But what they haven't got is they haven't got the experience of working with the body. It's not a criticism to anybody who might be listening and wonderful peers out there, because they're brilliant with the psychotherapeutic bit. And where psychotherapy meets kind of body work, you're in this realm of somatic work and trauma work. And the piece that I think, the group staff, how we heal that. I mean, I'm not for sure. Yeah. Coming back to your point about groups and what do we do with that and how can we deal with that maybe in a more collective way? There is no doubt that actually if we were able to, people have forgotten how to live in communities. If people live more in communities and support one another, actually there's good evidence to suggest that the trauma and consequent health issues are likely to be reduced.
I guess one very important factor, actually, I'm glad you said it, because I think that might be a big part of how these online communities might be working, is because they're doing it in group with other people who are suffering in the same way. One thing I was going to put you back on, you mentioned about you were with a colleague who kind of said your stuff, ostracized you and stopped the referrals. You touched on it there. So this kind of stuff we're talking about, a lot of traditional medical doctors, specifically who are maybe slightly older, of the old generation, would still consider all this as no, give them a painkiller, give them an injection. And so what's your kind of, how would you cope with that, especially in your field where you maybe get referrals from, you would well suited to get referrals from, say, orthopedic surgeon or rheumatologist. But also, what's your view on talking about nociplastic pain, which a lot of doctors still don't exist, to be honest.
Exactly.
They just think it's neuropathic or, it's not, it's not a thing almost.
Yeah. I mean, I suppose I've got to the point now where mercifully I kind of, actually most of my referrals, they're coming through different mechanisms now. And so, quite frankly, also the relationship, I used to know every single GP by first names and had a decent relationship with them in my town. And now, frankly, nobody knows who their GP is half the time anyway. Sadly, those relationships are dying quite a lot. We have great relationships with orthopedic consultants. But again, I'm not tending to see that many people from that. They go to my team who are doing the more normal, inverted commas, physio. So how do I deal with that? Well, one, I'm past caring. I'm old enough and ugly enough to kind of not care anymore, I think. So I don't mean that sort of arrogantly or disparagingly to my peers, but I recognize that they don't always get it. And I'm like, well, okay, that's all right, but I'm confident enough in the literature, and I'm confident enough in my experience to be able to go, look, I think we can sort of challenge that. I've always been a bit provocative and challenging, and the evidence-based medicine thing is important, but I think there's a balance of evidence-based medicine and practice-based evidence that, apples fell out of trees before Newton discovered gravity, right? So just if we're only going to do something that we know has already got robust evidence, if you extrapolate that in our thinking, then we would never innovate. Because if we're only allowed to do something that we already have good, strong evidence for, well, how do we move forward? We have to be able to go, what about this observation that I see? Do I have an explanation for it? No. Now I get really excited by that. And that's where I'm more interested to be. And then I go and look, can I use logic? So, for example, I did a video recently on the thyroid. And you go, well, all right, well, what's a physio talking about thyroid? Well, only because I treat chronic illness. And I'm going, well, how am I going to change that? I don't know. I can tell you that I have managed to get people to reduce their thyroxine intake by doing work. That wasn't our primary goal. It was a secondary effect of working with the rest of their chronic pain or whatever else. You go, well, why would that happen? Well, for example, okay, well, let's look at what controls the thyroid. Right. Well, from the pituitary gland, right? Okay, and then what has an influence descending down on the pituitary? Well, the hypothalamus. Now we're getting interesting because we know that the hypothalamus has also got some connection through to brain stem. And we know that the hypothalamus is also having a very important role in how it responds to environmental stressors. Yeah. And so if we are not coping with that, and we've got some brainstem stuff, there's our friend to kind of, the vagus nerve, etc., and overwhelm. And then the hypothalamus and its involvement in stress and how we cope with stress. If we're not coping with that very well, might that have a descending effect on the pituitary gland, which will in turn have a consequence on the endocrine organ of the thyroid? Entirely possible. Yeah. And you start thinking holistically in that way. So dare I say holistic without sounding like I'm going to start wearing a kaftan or something or other and burning joss sticks. Holistic in the truest sense. It just makes sense when we start to push the envelope of how we're thinking a little bit. So I'm sure I answered your question there about how do I deal with it and how do I deal with that nociplastic pain. Let's go to nociplastic pain because you asked me specifically about that. So,
yeah, the reason I asked about this is because a lot of doctors still, so you probably are aware that a lot of doctors like following the nice guidelines, right? I know you're obviously clear, but even the guidelines 2021, I think, changed for chronic pain specifically. And they mentioned in the guideline nociplastic pain, and they said that there's no role for gabapentin, pregabalin. I think there's only two, like amitriptyline and duloxetine were the only two that said it might have some benefit. They even named some therapies in the guideline. But despite that, I think a lot of people still they weren't aware of that. I think partly because of the timing when it came out, was obviously, around the time of the pandemic. But despite that, a lot of us still aren't oddly aware of that. And we're still, their first default is for nociplastic pain to give, a neuropathic painkiller,
Or pregabalin or something. Yeah. So, you know what? Why is that? I don't know. I mean, we're into a slightly philosophical question about why somebody's behavior would change or not change. And none of us like change, Some people really don't like change. And sometimes for us to change, this means that what we have to do is be prepared to ask, well, what if everything that I think I know is wrong? How much of science is what we thought we knew 50 years ago? It's certainly different to what I thought I knew 35 years ago when I trained. So therefore, we could probably extrapolate that what we think we know now is probably nonsense or not quite as it will turn out to be in 100 years' time. Otherwise, nothing's evolving. So if we accept that postulate is true, then it must mean that what we think now probably isn't quite right. And I'm okay with that. Some people find that very disquieting, and we could get into a massive psychological understanding about why people don't like change, because then it rocks the foundations that they're on.
Yeah, I think just with this specifically, where the reason I got into this and kind of stepped a bit away from the NHS was because I was getting all these patients like you, but nothing was working, nothing was helping. Not just this, there's lots of things, right? And it gets to the point where, why is that? The guideline is the guideline. You got to the end of the guideline, what next?
And now what? Yeah.
Yeah, and just okay. One other thing I think I got asked a lot about is, I don't know what your experience or if you have anything to say about it, is heart rate variability. It's obviously massive, obviously just in the general wellness space, but specifically some products have come out for chronic illness where it kind of, it's like a basic monitor they wear, and it gives them the score on heart rate variability in order to say, look, today your stress level is less, go out and do more activity, or you're stressed today, reduce your activity. I think there's something there. It's a start, but what have you come across that? And have you used it? And because I think you'd be more experienced in seeing people using that, because you do it physically almost with people every day.
Yeah. I mean, the way I view it is, I think HRV is a somewhat crude, but still it's immeasurable. And we live in this world where we go, well, okay, how can we measure this? And one of the great challenges of doing a lot of this somatic work is, there's some it's joining up the dots of like, well, there's some literature over here, some literature over here. That one of the criticisms is, how many sort of good double-blind RCTs are there around somatic experiencing? And it's very difficult to do it because it's so individualized, and because, well, you can't do a sham treatment for a start. So it's very tricky. But so, of course, we look to things like HRV and what can we measure? The way I view HRV is it is a sort of measure of the plasticity within the autonomic nervous system, because how effective is the sympathetic and parasympathetic balance to be able to manage that homeostasis and to be able to have that overarching regulatory effect on the heart rate. So we've got the SA node and the AV node just ticking away nicely, and then we've got this superimposed autonomic nervous system on the top of that, which is, and so really the evidence is, as you know, and what you're referring to is that in a way, the more plastic someone's system is, the more capacity that they have somehow, then that seems to be measurable by them having a better HRV value.
Because that leads into the criticism which you mentioned, which a lot of people have with this, is, look, if you see someone and they get better with your EMDR or your physio or your somatic experiencing, how do you know it was down to that and nothing else happening externally? Because there's no measurable, I guess, outcome apart from the patient saying, I feel better. I guess just being balanced, the argument some people might say, in particular traditional, medical doctors or therapists, it's not what you're doing, it's just their life situation may have changed for the better potentially.
Absolutely. And you know what? My instant reaction to that would be, okay, and what about paracetamol? Yeah. Because there's a placebo effect with everything that we do. You know what? And again, I think I can probably quote Gabor Mate in this one, that because I think he quoted this at the Trauma Masters Conference in Oxford last September. And there's research around this. Do you know, certainly in this realm, what the greatest predictor of outcome is for almost any intervention that we have with our patients? One of the greatest predictors of outcome.
I'm going to guess nuclear family support or something, but I don't know.
The client-therapist relationship. The relationship you as a doctor have with your patient will have a greater influence than any medication that you choose to give them or any therapeutic intervention. So you could do EMDR or you could do somatic experiencing. Now, personally, I do believe, and my experience is that, because I know that you can go, wow, that was the right doorway that I went through today. And there is more than the relationship. There is no doubt about that. But one of the greatest predictors is, and listen, if you can't get the patient to be on your side or you don't feel you've got a strong relationship, chances of them, we all know the studies around like adherence to, drug regimen and things like that. I remember looking at that for an undergraduate paper that I had to write on patient compliance. And one of the greatest predictors was that relationship with their doctor. And, insulin being taken by adolescents was better when they felt that they had a good relationship with their doctor. Yes. So, I get this kind of bit of a gut. Well, well, you know what? If there's a part of me that I'm not trying to say that this is like I don't care about science, and this is the great challenge that we have. But I'm not a researcher. I'm not, and so I don't have that challenge to worry about. I'm mindful of it, but I'm a clinician and I treat people, and I go, you know what? If I wiggle someone's left ear and their pain goes away, we're going to just wiggle their ear again. because I do think that actually we've become, I think we've forgotten the human element of what's going on, and we can be too clever and too scientific about, well, yeah, but have I used that drug or that one? I mean, let's be, 10 years ago, everyone was whacking out pregabalin, and now we're going, no, don't do that. So what's really going on? What is really going on? And I think the human element is really important. And the art of what we do is something that we can't forget.
I think the stuff you do and this whole area is something we have to explore more, because traditional medicine, as we know, is not working. And I'll be honest, the response I've seen from patients going through whatever chronic disease it is, they're beginning to realise now they're looking for other things, and a lot of them are good results. And like I said, we all like looking at RCTs. I mean, the only way you can possibly do it is if someone goes through a program, but then it's still hard to do like a really accurate one, like I could with the medication. Where if I give you this, how bad is your pain? Like it's a really, really difficult thing to do. And I think I'm evidence based. I'm happy evidence based. But I think when it comes to these chronic conditions, like we should try and make the patient better. We forget sometimes that underneath all this, there's a real person, right? And that's what I think. And that's what I think. What you explained really well was, how you can bring someone back from where they've kind of, going out of line or the fork road, how you can do it. Interesting. So you mentioned obviously. So one aspect was, you said at the beginning, right at the beginning of the conversation about all the things you've done. You mentioned acupuncture, and I've had a lot of people kind of ask about that. Has there been a role? I mean, do you do that anymore, or is that kind of just long gone?
It's kind of long gone, but I'm very grateful for having done it. There is another thing, and again, I'm self-checking myself here because I'm going, oh, crikey, she's going to be going out there, and what are people going to think? But I've got braver, and I'm kind of said I'm a bit past caring. It might backfire on me, but anyway. But again, I think I can say this because the science is catching up with it. Now, do I fully agree with the principles of it? Well, it was a model that allows me to work. But again, there are some, from a Western acupuncture point of view, then there's some stuff around pain. But they weren't very good at actually accepting that it could do something other than manage pain, because they didn't have a mechanism. And we kind of went, well, what's all this meridian stuff? And what's all this chi and energy and stuff? And that's not something that we really think about in the Western world. But I just began to see a lot of results. I mean, it was when I was back in the NHS, working in the north, and I just saw results. And I thought, listen, this is just useful where sometimes nothing else works. So let's try it. Now, as I've gone along, then, and I've mentioned, I probably learned more about kind of energy as a martial artist, actually, than any other form of treatment that I've done. And when you mention energy, and even the Chartered Society of Physiotherapy have now actually, so for a period of time, there was a specialist organisation, a subgroup within the Chartered Society called the Association of Chartered Physios in Energy Medicine, and that covered things like reflexology, people working with chakras, acupuncture, not so much acupuncture. And it was like, some of us that were into sort of the more peripheral stuff, and they've now said anything that is that uses the word energy isn't part of physiotherapy anymore. It's not covered by that insurance, so I have to use a different insurance for that. Why am I jabbering on about this? Because I just go, listen, everybody knows when someone walks into their space and you're standing in the queue in the supermarket and you can feel someone come in your personal space. You could try it out. And actually, great work, that's good scientific work by a company called organization like HeartMath. They have now measured electromagnetic energy fields radiating out from the heart, which go out a good several feet. Some studies say 3 up to 6 feet. So actually, when energy fields are overlapping, there is no doubt that we are energetic creatures. We are an energetic being. When you start looking at, they might call it chi. Japanese would call it ki. Indian cultures might call it prana. Yeah. I don't care what you call it, but it's a thing. And actually, when you start to notice that, and is there a flow around the body? I don't use needles anymore. Now, this might sound very strange, but I actually got, when I was doing other work like cranial work, I can feel shifts in the body. I don't know, and I don't care whether it's going up the spleen meridian, past tearing. I feel a shift in the body. The patient goes, right, that feels congested there. That feels stuck. Can you feel that? Can you feel how, like, yeah, I really can. My leg feels a different weight. So when you get people into a somatic awareness, they'll come and they go, right, it's not about, what do you notice? Okay, well, I've got this pain in my back. Right, okay, yeah. Can we go beyond that? I know you have that. So, and as you lie there, what do you feel in your right leg? What, you know you have a right leg. Now you think about it, it doesn't have a hard edge. It kind of blends with the room, right? Yeah. Right. But you know it's yours. Right. Okay, so that's the sensory experience of your existence. Yeah. Now, yeah, as we work, can you feel it? Yeah, it's got like a wavy, rhythmic quality to it now. Yeah. Can you feel that in the other leg? No, I can't. Right, exactly. And so you go, right. So there's sort of a different quality of activity going on in the body. Now, we could look at whether that's actually changing blood flow. We could look at whether it's actually fascial tissue changing in a myofascial argument. That's a perspective that we could look at. We could also say, well, are we just having some tactile input here, which is affecting the sensory motor cortex in some way? Well, great. Well, that's going to be hugely important if we're dealing with pain. And going back to your point about nociplastic pain, one of the great, when people go, well, it's got to be all nociceptive, and if there's no inflammatory stuff there and there's no mechanical stimuli, it's this mechanical model that we've got stuck into. Is pain equates to there's something broken. And, we know that that's not the case. And actually a perfect example of this, which we've all known about for decades, is phantom limb pain.
Yeah, absolutely. Yeah.
Right. Well, how is nociceptive pain an explanation for this phenomenon we know as phantom limb pain, the dreadful pain in the foot they no longer have? It can't be nociceptive.
Yeah,
It's
I think that's
sensitization of some description.
I think that's a very good way to maybe make people who don't believe in it, because it's, I think we all know about that pain. I've seen someone with it. Look, Roger, thank you so much. My head is like, it's full.
We could go on for hours, couldn't we?
I think this way of thinking is a shift, especially for a traditionally trained medical doctor. But I'm really open to this kind of stuff because I think it does work. I'm trying to process it all and just almost learn these things alongside traditional medicine. And sometimes the two conflict, but I think speaking to people like you really does help. So look, thank you. I mean, it's been over an hour now. I know we agreed an hour, but thank you so much for your time.
Welcome. Good to chat.
Absolutely. We'll process all this and hopefully get you back on someday soon to pick your brain.
Yeah, that'd be great because there's way more, isn't there? We go in many different directions with this. It's been lovely talking to you, and thank you for inviting me. Thank you.